our healthcare system so much, and we want to see it improve and become better than it is right now. So it is really commendable, and I don't take this gesture of everyone being present this early morning to listen to what we're saying, to discuss and have a conversation that would move towards breaking barriers, changing narratives, and also making our healthcare system better than it is for all of us. So I have a couple of slides that I think we're going to go through. Um, is it going to be showing from your own side? I think you have the slides. Yeah. All right. So this whole conversation today would be around the healthcare giver, our healthcare givers in Nigeria, the healthcare providers in Africa, the healthcare providers in the world at large, the challenges that they go through, and how we are going to navigate some of these challenges and find solutions to some of these challenges. We have all realized that with time, we've come to the realization that we, the younger generation, we are the ones that need to take the mantle of leadership. The drivers of how our healthcare system is going to be driven in the next future, in the nearest future, regarding to the care that we give to our patients and the care that we as healthcare providers receive as well, which is why this discussion is very important. For centuries, for centuries, we have had the relationship between the patients and the healthcare providers in general, being it a doctor, nurses, pharmacists, dentists, community health extension workers, all the other allied health professionals. The relationship has been one that has stood the test of time. And it has proven to continue like that, till the end of time as well. Now, one thing that has not changed over these years is the fact that we have patients who come to the hospital seeking for healing from the healthcare providers. And then we also have healthcare providers who are also human beings, who are also people with their own families, just as the patients are, who are also people who can be afflicted by sickness, illness, by all the challenges of life as well. And despite being the same as the patients that come to the hospital, they hold their own ends together. They still come to the hospital and provide care. The big question is, which was my first slide, the big question is, when these healthcare providers fall, who is going to pick them up? When these healthcare providers fall sick or fall ill, who is going to provide care for them? When these healthcare providers are being subjected to assaults, assault from the fractured healthcare system itself, or assault by the people that they take care of, which of course it is actually happening, who is going to be there for them? And this is the whole essence of our conversation today. And I want us to think through, while we navigate this topic today, I want us to remember at every slide, this is the question that we're trying to answer. This is not a witch hunting. This is not a blackmailing. This is not a day to look at or push blames or whatsoever happened to whosoever. This is a day to find solutions to our problems, because all of us that are here, actually care, and we want to see our healthcare system become better. As I've said earlier, if we look at the early times of medicine, right from the 19th century to the mid 20th century, you would see a progressive wave in the sense that we have, when from the times when healthcare provision was solely solitary, and it was solely with traditional healers. It's solely in the hands of traditional healers all over the world, and that time you would find that the number of traditional healers to the number of patients has always been at a very critical point, where we have very low healers, and the number of the population, which is always growing, is always higher than the healthcare providers. Globally, in the 19th century, it used to be with just the traditional healers until around 1858, when the germ theory was validated, which was populated by the Posture and Koch, and also strict licensing laws were now being rolled out about the medical practice. That is globally. In Africa as well, that was the time of the colonial masters coming into Africa. We had our traditional healers in large numbers, and when the sorry, I'm finding it hard to focus once my when the colonial masters came into Africa, they brought about the institutionalized healthcare provision as well, in terms of medicine, a structured guideline kind of care. And in Nigeria as well, it was the same thing. That was the time when we started having our institutions, our medical institutions being built. Our first institution in 1890 was the Sacred House, in Abeokuta. Then came the Yaba Medical School, then the UCH Ibadan, and then that was when we had an increase in the number of now institutionalized, rather than the traditional healthcare providers. We now have institutionalized, licensed medical doctors, nurses, and all of that, and all have you. In terms of health workforce as well, the early era, like is the 19th century, the pre-colonial era, you would have just the same thing, healers that were outnumbered by thousands of of patients. And while we started having universities being built across the world, then the number of healthcare providers started increasing. And to every nation his own. Africa, with all their medical universities, we are now producing more healthcare providers. Nigeria as well, we're now producing more healthcare providers. And the situation has been one that we had healthcare providers, low healthcare providers to patients then, because there was no, that was when the medical schools were starting to come up. And but everybody stayed in his own home country. Everybody, took care of their own people. Come to 2026, today, we have about worldwide, we have about 65.1 million healthcare providers, out of which 12.7 million of those healthcare providers are doctors worldwide. And Nigeria has about, 80,000 doctors, which is registered healthcare providers, while only about 40 or less than 40 of them are actively practicing. In the next slide, before we move to the next slide, I'm going to talk about the evolution of the disease burden, because while we're having an increase in the number of medical universities, an increase in the number of healthcare providers who are there to take care of our people, we also have the disease part, who are also, revolutionizing, so evolving as well. We now have a situation where globally we used to deal with infectious diseases alone, but with the coming of antibiotics and vaccine, we found eradication of, some diseases like the smallpox and all of that, leprosy and all of that, control of other diseases like tuberculosis, malaria, and all of that, to a situation where when we started adopting different, approach to our diet and our sedentary life, we started having increase in the number of non-communicable diseases like hypertension, and stroke, diabetes, and all of that, being the highest burden in globally or in the Western world. If you come back to Africa, you will find that it is a double burden because we still deal with infectious diseases and still deal with the non-communicable diseases as well. In Nigeria, it's still the same thing. In the pre-colonial area, we just have, a containment-focused kind of containment of malaria, containment, maternal mortality, and all of that. While in the daily reality today, we have massive surge in the non-communicable diseases as well, while also dealing with the infectious diseases. So if you look at this, we're having an increase in the number of healthcare providers and also an increase in the burden of diseases. In Africa and in Nigeria, we have a double burden while we're dealing with infectious diseases. We're also dealing with non-communicable diseases. Why is this essential? The essence is that if we're dealing with something as strong as this, then we should have a stronger healthcare, a stronger health workforce. But that is not the case. In the next slide, we would see that what this translates to is that while we harbor 23% of the global disease burden in the world, Africa in general, we have just less than 4% of the global health workforce. You can only imagine what that translates to. This is just saying that we have less than 5.1 million. Out of the 65.1 million healthcare providers in the world, most of them are concentrated in the Western region. We have only 5.1. We are 1.4 billion people in Africa. This is just an estimate. We are about 220 million people in Nigeria. We have less than 4% of the global health workforce. I need us to take a moment to let that sink in. This is what we are dealing with. In the next slide, we would see that while we have less than 4% of the global health workforce, in a survey, in one of the African World Health Organization, research that they did, which they accumulated the healthcare, they looked at the healthcare workforce across a 10-year period. They found that about 2.7 million of this less than 4% that we have of Africa's healthcare workers, that is including the doctors, the nurses, all other healthcare providers, about 2.7 million of them are practicing outside of Africa. So in reality, less than 4% is far, far less than 4%. But the disease burden is not distributed outside of Africa. The 23%, even more than 23%, we have it in Africa and it's still rising. And we're dealing with double burden. This is our reality. And this is why why it is important to know why these healthcare providers are constantly leaving Africa to practice in other countries. Because if we do not ask ourselves those questions and find solutions and find them a way to retain our healthcare providers, we might wake up to a day where we would have about 80% disease burden and then just less than 1% of healthcare providers. And God knows that we do not want that. We do not want that to happen. In the next slide, this is the reality of doctors in Nigeria. As earlier stated on, we have about 80,000 doctors, while actively practicing about 80,000 licensed doctors, but only about 35 to 40,000 that are actively practicing in Nigeria. Now, even that 35 to 40,000 as of 2023, you would see that about 25% of those that work in the NHS in the UK are Nigerians. They are Nigerian healthcare providers. 25% of the health workforce in the NHS in the UK are Nigerian healthcare providers. So about 1,000 of healthcare providers leave Nigeria every year to other countries, be it the UK, the United States of America, or other countries for greener pastures, they say. Even this number is severely skewed negatively. Why? Because even those in Nigeria, there are some that are not practicing. There are some that have lost their lives already. And all these numbers are not accounted for in this 35,000. So this is just to show you that we have far less number of healthcare providers, doctors specifically, than what is reflected on in the registries. In the next slide, we will see where these healthcare providers are going. They move to the UK, to the France, to the Canada, to USA. What this shows us is that there are some factors which we call the pooling factors that these countries have that we do not have, which is pulling our healthcare providers to them. Now, these healthcare providers are, this is just for doctors. These are doctors which most of them are trained in our home country, that is in Nigeria, some trained outside of Nigeria, with subsidized education. We always bring, when you meet the political people, they always use that as a bait, to always discuss that healthcare providers are being trained with the country's resources, yet they leave. It is true. We're not denying that. Yes, but if I should invest in whatever it is that I invest in, then it is just on me to take care of my investment. I would ensure that whatever I invest, I would make sure that I reap what I invest from it. But when you show every single day that you do not care, every single day, every point, you show that you do not care about your investment. Nigeria spends billions of dollars on training our doctors, our nurses. We all know that our education system is cheap in Nigeria. No matter how expensive it would be for the average Nigerian man compared to the global standards or the global global prices for education, if I may put it like that, it is relatively very cheap because it is highly subsidized. But then we do not take care, the country as a whole, the nation as a whole does not take care of its investment. And that is what is bringing all of these issues. Which is why in the next slide, we're going to look at the factors exactly that is causing these healthcare providers to leave. While those countries have the pooling factors, we as a nation that do not take care of our investment have the pushing factors. These factors are the factors that push our healthcare providers to leave the country. There is no healthcare provider who is not passionate about his country. We should put that and let that sink in. There's no doubt. We all started this fire in us that wanted us to study medicine, wanted us to become a nurse, wanted us to become dentists, wanted us to become community health extension workers, because we want to care for our own people, because we want to change the narrative of health in our own country. The passion is there. The decision that it takes for someone to leave the country and practice in another country is not a small decision. This is where our families are. Our countries are where our families are. There are places where we have our fathers, we have our mothers, we have our sisters, we have our siblings, we have our loved ones, our friends. So to leave a country like that, to go to a place where you have no one, to start life from the beginning, is not an easy decision. And that is why whenever they bring that clickbait, that political tool to say that we are not patriotic, and that is why we are leaving, we say that it is an absolute lie. Sorry to use that word. It is an absolute lie. Every single day, we have reasons to stay, but every single day, we are seeing reasons not to stay. Patriotism does not pay your rent. Patriotism does not pay your children's school fees. Patriotism does not save you when you're being assaulted by the same people that you take care of. Patriotism does not do that. And this is why, again, we must ask the question. So who cares for the patient, or who cares for the health caregiver when he is down? These are the pushing factors. And I've decided to generalize it under 3 themes. The working hours and workload. We all know this has been a problem for centuries, right from when the medical schools have been renovated. I mean, those medical schools were constructed in Nigeria or in Africa at large, and medical doctors or healthcare providers started, being produced in those places. We put healthcare providers in hospitals, and they provide care 24 hours round the clock, every day of the month, every month of the year. And we do not care about their own, whether they're exhausted, their burnout, their own capacity to take care of people that they have sworn to take care of. In Nigeria, for instance, we have very unregulated working hours. You might find a healthcare provider going hours without even a single break to catch his breath. And this has been going on for years. And there is no national guideline, there is no national policy whatsoever that ever looked at this. Never. I mean, we've had so many documents that come out, so many documents, so many progress in our healthcare system. In the training, we have the Medical Residency Training Act that came out in 2018 and outlined a very beautiful training methods for training our healthcare providers. But it missed out on one very critical thing, a very important thing, the rest that those healthcare providers deserved. The second thing is the remuneration issues, the poor salaries, delayed pay, lack of incentives. This has gone on for several years. And we are known for strike actions every now and then in Africa, in Nigeria, in other countries, to demand for what is rightfully ours. You go to work, you spend the hours, you are overburdened, overworked. Now it is time for you to be paid. You are underpaid. It is time for you to be paid. Your pay is delayed. It's time for you to be paid. Several years of your pay is being withheld. Several months. You wake up to go to work every single morning because you are needed. But nobody cares about your own portion of, incentives. What should always push you to wake up and say, I want to go and work? And this has become a normal because for centuries we have taken healthcare provision to be an act of either charity or a noble act. And so whenever you come out to speak and demand for your rights, you're being labeled as ungrateful, you're being labeled as unpatriotic. The welfare and security of the healthcare providers contributes greatly as well. These are hospitals that lack basic equipment. We have healthcare providers that do not have personal protective equipment, no running water, no constant electricity. And that is how they practice. You are an emergency care doctor. You are an emergency healthcare provider. You are an emergency nurse. The least you should have is when patients come, you should have everything available to you to intervene swiftly. But then here you go. Patients come to you in need of oxygen, but you have to write it to them to go and buy the oxygen cylinders. If they can't afford it, you can't do anything. You have the knowledge in your head. You don't have the resources to take care of them. When patients come to the hospital, you have to write for them to go and buy cannula. Someone is in shock. Someone is in shock. Someone needs to be resuscitated. Someone needs intervention immediately. A young child who knows nothing of what is going on in the world. He only needs to be well and play. But then you have to write cannula for the parents to go and buy cannula. 100 naira. Our hospitals cannot provide that. 100 naira. These are the conditions that we find ourselves in. You are battling with every single day. You're battling with excessive workload. You're battling with poor remuneration. You're still battling with the lack of availability of these basic equipment. We're not talking about MRIs. We're not talking about CT scans, which God knows they are very important as well. We're not even talking about them. We're talking about cannulas, oxygen cylinders. We're talking about bed spaces. We're talking about bed nets. We're talking about all of these essential things that needs to be in a healthcare provision place, an institution, which they are not there. And that is how you work every single day. Then comes the biggest hit of all. While you're doing your best. Of course, with all of these things, frustrations comes in. There are no guidelines for you. Frustration comes in. You act in a way that you're not supposed to act to patient relatives. You missed out on some things. You misdiagnosed some cases. You are exhausted. And when you expect a compassionate, reaction from those patients or patient relatives, you met with negative compassion. Some go as high as assaulting you, beating you up, locking you in cells. Those with power who feel they have the ability to get whatever they want, they lock you up. They do everything in their power to make sure that they get what they want. They do everything except doing what is right. These are the push factors. When a doctor comes one day and sits down and then he realizes that with everything that is going on, he looked at his family, his child is sick, but he does not have an insurance that covers the sickness, the illness of his child. And he had to watch his child die or his wife. Or he had to watch his children drop out of school because he cannot pay for their school fees. And then you have other countries who give you your whole salary of the year in a month, what happens? Where your children get education free, where you have more time for family, where there are regulations that guide how you practice, make things easy for you, where you don't have to worry about every healthcare system has challenges. But in those places, you don't have to worry about the simplest of things: gloves, water, constant electricity, cannulas, cotton wool, spirits. You don't have to worry about any of this. If you need them to work, you have them available. What would happen? Then you find these healthcare providers living. And not in small numbers, they live in troops. Brain drain, they call it. Of course, brain drain. What else? What else? In the next slide, we would see that this is the saddest reality. This is a study that was done in Nigeria about the average working hours of doctors in Nigeria is 106 hours a week. How many hours do we have in a week? We have about 160 hours in a week. 106 of those hours, someone is working on his feet without breaks. We've had several instances of where doctors post their rosters. They are inhumane rosters. They work every single day of the month. You're on call what being on call means: you're on call for 24 hours. You are in the hospital. Now, the physical torture of being present in the hospital alone, with all the unavailability of the things that you need to work with, that alone takes a toll on your mental health for a day, not 2 days, not 3 days, for a whole month. Why? Because that department only have one registrar or one house officer or one senior registrar or one consultant to do the job of 10. When we have less than 35,000 doctors for 220 million people, when we have less than 5.1 million healthcare providers in Africa doing the job, taking care of 1.4 billion, the healthcare provider to patient ratio becomes one that is barely, very, very lower than what the World Health Organization recommends for basic healthcare provision. You're talking about one doctor in some states like Zamfara. You have less than 0.5% to 10,000 patients. That means one doctor or one healthcare provider takes care of about 20,000 patients. One. In some general hospitals, we have just one. This is our reality. And these are the push factors. In the next slide, we're going to see that what this translates to is this effects that they tend to harbor, or they tend to have from this excessive workload. In a recent survey that I carried out of 776 Nigerian physicians, and this is from all cadres: house officers, resident doctors, consultants, people who are ready to open up. 776 of them in this survey, when asked what are some of the occupational health crises that they have experienced, 81.8% have experienced stress-related headaches from the job, 70 from anxiety, depression, about 15% have experienced fainting or collapse at work. This is not a small number. Road traffic accident for which some have even lost their lives. Now come to the saddest of them all. It might represent the lowest number here, 8.6, but I tell you, it is the most devastating of them. When your work starts to take care of your loved ones, the women that have experienced miscarriages at work, imagine you just had, for the first time after your wedding, you had the love of your life. You're carrying one of your lineage that you would want, someone that you would want to nurture. And then all of a sudden, the job that you so much loved takes away the person that you so much love away from you. We've had instances where mothers who have experienced miscarriages, I have had messages from mothers who have experienced miscarriages telling me that they don't even consider that I've just had a miscarriage. They're telling me to please come back to work. Why? Because we don't have enough hands on ground. This is our reality, day in, day out. What happens when a woman has a miscarriage? The risk of another miscarriage increases. Yes, the risk of another miscarriage increases. That means the chances of her ever having a child again decreases. This is what it means. Now, until we start to look at these numbers beyond just numbers and start to look at them with human faces behind them, then we would understand why it is important for us to ask the question, who cares for the caregiver when he falls? Who cares for the caregiver when they lose their children? Who cares for the caregiver when they lose their lives? For some, they are the only ones, the breadwinners in their family, they say. Your family contributed what they have to send you to medical school. You graduated, everybody is happy. Some of this burden will be taken off the shoulders of your parents. This is the noble profession, as we say. At least you're going to earn something better than other people in the country. And there you are, you're not earning enough. You're being overburdened, you don't have time for your family, and still the system takes your life away. The only survival line for the whole family just lost his life. These are no stories. In the next slide, we would see that this actually occurred. This actually happened. Behind these numbers, we have people who have lost their lives. In that same study, we looked at what we call the exhaustion index. And when we asked the question to the 776 healthcare providers about how do they feel the next day after a 24 hours call. Why is this question important? Because in Africa, in Nigeria, we have healthcare providers now going after their 24 hours call. They still don't have break. They're still expected to come back to work the next morning and continue the day's work till the ending, to the closing hours of that same day. That means they can go for 36 hours straight without any break. What does that translate to their own body and to the decisions that they give to those that they take care of? When we put 0 as you are, if you, the next morning you present to work, you are like very refreshed and there is no problem. 5 when is you are moderately, being affected, you're exhausted and all of that. And then 10 being fully dysfunctional, clinically drowned. Most of the majority of the respondents, the average respondents was 8.15. This is not just a figure. This can only mean two things. On a scale of 0 to 10, when you have 8.15, it shows that there is a general exhaustion. What does a general exhaustion mean? Means that majority of the healthcare providers always present to the work after 24 hours call very, very drained. Very, very drained. And it also signifies that this is a very, very critical figure. A danger figure. Because a fatigue score of, in other studies, a fatigue score of 7 is considered dangerous. It is equivalent, always equivalent to clinical alcohol intoxication. When you are sleep deprived, they equate it to being intoxicated by alcohol. You can imagine someone that is at the level of alcohol intoxication, taking decisions, lifelong decisions on patients. But the nation doesn't care because every single day they put those same people on the front line to take those decisions. The saddest part is that most of the respondents, about 94.7, this is the whole respondents, 94.7% of them showed their intent to migrate. They want to leave if they have the opportunity. That means if today the foreign countries open their doors without any exam and say, if you want to come, come, all of them will leave. Remember, we said it is not it is not a light decision to decide that you want to leave. You must be pushed to the wall. They are not running away. It is a systemic survival strategy. What can we do? Must I stay and lose my life as well? In the next slide, these are the faces behind the figures that we've been talking about. Now, this is just tip of the iceberg. These are cases that came to the light. These are cases that are reported. There are so many other cases that are not reported. So many doctors, so many nurses, so many healthcare providers who have lost their lives, who have been assaulted, that are not reported. Sadly, in 2023, we lost a doctor after being subjected to 72 hours call. We didn't learn from that. 2 years later, we lost another doctor. What do? We hold processions to honor them for their sacrifices. The truth is, they were not meant to sacrifice their lives. They have sacrificed enough by being present. They also have families who have lost them now. That is not enough. We've had several assaults in Damatru. We've had several assaults where a patient just feels like flogging his doctor. Can you imagine? You are the patient. I'm your healthcare provider. We had little misunderstanding. You felt the need to flog me. The same thing in Kwara. A doctor was assaulted. This was in the maternity ward where life is brought out. Now, when you think it's just affecting the lower grade doctors or the healthcare providers, then came the heat of them all. In a country where we have laws, in a country where we need these highly skilled healthcare professionals, a professor of medicine was not safe as well. Professor Eyo Ekbe Nakwaibom was assaulted by none other but our security operatives, those who we should feel comfortable around. They came to the hospital, a sanctuary, a place of healing, and they caused havoc, chaos everywhere. You would think it's because of a crime that the doctor committed. No, they just needed certification of a medical report on a crime that they are trying to uncover. They picked him up, arrested him, took him to their custody. This is no other, just not any doctor. He's a cardiothoracic surgeon. In the whole world, we'd have only about 17,500 of them. In Africa at large, we have barely 1,000 of them. In Nigeria, we have only 80 of them. And almost half of those 80 don't even practice in Nigeria. So we should have about 40 of them. In Akwa Ibom, where this doctor was assaulted, he is the only one, a cardiothoracic surgeon. What did he get at the end? Apology. After several pressure from the public. Now, this kind of accountability is what we must always ask for. This generation, our generation, we should be driven by this data. We should be seen being proactive in ensuring that our healthcare system is saved from the hands of these politicians who have no understanding of what saving lives means. In the next slide. While all of these things is happening, Africa at large, we have only 1 in 3 African nations that have prioritized the workforce migration policy. Just 1 in 3, about 33%. We have about 54 African countries and about 45 that are under the World Health Organization African region. Only about 1 in 3 of those African countries prioritize health workforce. In the next slide, we will see that Nigeria is one of them after a long time. Just in 2024, they finally agreed on putting on a policy that will now start looking at this health workforce migration and curb the surge in this health workforce migration. Commendable, beautiful document. But in the whole of the document as well, some pieces are missing. But we would only come to talk about those pieces, like the explicitly talk about, regulating the working hours, the payment, the incentives. We can only talk about them when this document is implemented. 2024. We are in 2026. It's up to 2 years now. Still, this document has not been fully implemented. We cannot continue to have beautiful documents without implementation. These documents without without them reflecting on the lives of the average Nigerians, the healthcare providers, is not a decorative monument. They're meant to reflect in our lives. Who cares for the caregiver when the caregiver is down? In the next slide, I intentionally put this slide because I want to talk about the fact that as a nation, I would take Nigeria, the whole Africa during the Abuja Declaration in 2001, the African countries came together to look at the healthcare, the crumbling healthcare, and say that, look, our healthcare system is drowning. We need to scale up our budget, our budgetary allocation for healthcare, so that by 2030, we would have a universal health coverage. One of the very basics that this Africa, the borderless healthcare said earlier. Universal health coverage. What does it mean? That everyone, regardless of your religion, your tribe, where you are, your financial status, you get to access health from wherever you are. A beautiful thing. And they decided to put about 15% of their yearly budget to health. 2001. This is almost 25 years later. We have just a number of African countries who have gone above 8 to 10%. Our dear Nigeria is still less than 5%. Yes, sometimes we cannot blame them because, of course, when you look at what healthcare contributes to the largest, to the GDP, to our GDP, to our gross domestic product, yearly, you will see that it is less than 1%. So the government doesn't see any returns. You know, everything is business. The government doesn't see much return on health. So it doesn't, we could assume that it doesn't see much return on health, so it doesn't give more. We're still at less than 4.2%. And every year, this 4.2%, not all of it go to the hospitals, not all of it go to the primary healthcare centers, not all of it gets released. Bureaucracy, corruption sets in. A minister of health is there, but he doesn't have resources to work with. A minister of health is there, but he always has to answer to the president. Why is that? It's because we are not investing in our health. Do you know that yearly Nigeria loses about $1.2 billion to medical tourism? Yes, about $1.2 billion to medical tourism every year, paid on flights, paid to those hospitals outside of Nigeria. We are literally funding their healthcare system. That's basically what we're doing. Our politicians will rather move out of the country and seek healthcare outside of our own shores. They know it's good, so they go there. But the problem is not them going there. They carry our resources and take it there. 1.2 billion, if we could save half of that and invest it in our healthcare system, we would have a better healthcare system that we're talking about today. Yearly, we lose $1.2 billion to medical tourism. And the tables has turned. Because we are so brilliant, our healthcare providers are so brilliant, we have occupied every single nation outside of our shores. So when you live and go and seek medical healthcare or in other countries, you go and meet a Nigerian, you go and meet an African, the best cardiologists in the world, pediatricians, ophthalmologists, the best of them all. You will find Africans there. So we're not only exporting our brilliant minds, we're also exporting our finances, our economy, our funding to those countries. It's a win-win for them. It's a win-win for them. We train our people with our own money and we lose them. We don't care. Every year we graduate about 1,000 and 1,500 medical students. And every year we lose almost half of them. The greatest threat is that these medical students now, if you should take a survey and say, do you want to practice in Nigeria? Most of them will say no. Why? Because they have understood the reality of what is on ground. This is the chaos. This is the critical chaos that we are not even looking at. People have lost interest in the practice. We are not investing in our healthcare system. If only we could invest back, then maybe we would upscale our funding above 5%. National Health Insurance Scheme. Our National Health Insurance Scheme, which is supposed to subsidize our healthcare, is still less than 10%. 2 years ago, it was less than 5%. Meaning it has covered less than 5% of the population, mainly those that are working. That means 75.6% of Nigerians, of our whole population, are still funding for their health care from their own pockets. What does this mean? One major illness in your family can run your whole family into poverty. Do you understand that? We are not investing in our healthcare. God has blessed us with so many resources. The most of them all is human resource, abundance of it. We do not understand that a healthy nation is a wealthy nation, because when everybody is healthy, then your GDP will go up because everybody will be working, everybody will be contributing back to the pool. It's either we know it and ignore, or we don't know and we remain ignorant. We choose to remain ignorant. In the next slide, I want us to ponder upon this slide. I ended by saying, oh, we choose to remain ignorant. Now look at this shore. This is the picture that captured my mind. Nigeria has 853 kilometers of Atlantic coastline. And the world does not know a single beach by name. This is not bad luck. That is a choice. It's a choice we make every single day. We are surrounded by everything that should make us prosperous, but we overlook it every single day. We have the best of healthcare providers, but we lose them to the outside world every single day. That is not bad luck. That is a choice. We have what it takes to increase our national reserve, but we spend most of it outside the country. That is not bad luck. That is a choice. Where do we go from here? What is the way forward? I think we have done justice by saying that the three triads that we have mentioned as the push factors, if we can come together and create a system that looks into them, then we would have a better healthcare system than we have now. Not for me and you alone, but for the patients that we take care of, for our own families, regardless of where we are. And that is why it is important for you, for me, for all of us, for the growing generation to understand that we must begin to hold our nation accountable. We must begin to hold research. Borderless Healthcare Africa is doing that. So many other people are doing that. You as a person can also do something. Speak. Ask. Ask for accountability. Our nation has built the African Medical Center of Excellence, and everybody has been applauding. People have been going there, politicians, to take pictures. Cancer centers, beautiful. We need that to grow. We need all of those to grow, but we must remember that our nation does not only need buildings. Our healthcare system does not only need buildings, but it needs protection for the people who are taking care of lives in those buildings, who puts the lights on in those buildings. And I just hope that we get it better. In the next slide, it's everything that I've talked about here, where we have our healthcare providers being transported, we're exporting them to other countries, and we're not investing in our. So we must have Physician and Clinician Safety Act that protects, that puts a cap on the number of hours that our doctors, our nurses, they work, that they have their breaks, that they have time for their families as well, that they don't go through depression, fainting at work, having miscarriages, included in the burden they carry for taking care of people's lives. He who works should be adequately compensated for. To achieve universal health coverage, we must have healthcare providers who are well-trained, who are well compensated, and adequately distributed. If someone works, the least you can do is pay him for the work he has done. We must have incentives as well that would make our healthcare providers start to think inward, start to think that I have a reason to stay. We must start to think of health as an economic pillar as well, as we have explained. I think we're running out of time. The last slide. I just want to end our conversation today before I'm sure we would have questions and other things to discuss, but I think we would not do justice that we gather and we leave this place without thinking about other aspects of the turmoil that we find ourselves in Africa at large, and most especially in Nigeria. We've had several abductions, kidnappings, banditry, ravaging houses, homes, destroying people's lives every single day. On the morning of May 15th, 80 children across states were taken into by bandits, and they're still in the bush. So when you see rain falling over your roof, remember that we have children who are still in the bush, and the rain is falling on their heads. When you feel cold, they are there in the bush without covers. When you feel hungry, remember that they're there with monsters who do not care about their hunger. When you go to the hospitals taking care of sick people, remember that there are children there who are exposed to the cold, who are exposed to the harsh realities of the forests, who do not have the access to healthcare. We remember them and we pray for them. And we also pray for their families and pray for their safe return. Thank you very much, everyone. And I hope we had a fruitful conversation. Thank you.
Thank you so much, Dr. Alamin. Thank you. I can't see the applauses. I don't think they're enough. Please, let's have. Thank you so much. Give me a minute. Thank you, thank you, thank you. We've had a wonderful conversation, and me myself, I think I'm feeling the push factor because I got back from work not so long ago, and I am here talking and like acting as though it's normal. It's not normal. So thank you guys so much for joining, for the wonderful conversation and for the insights we have gained so far. We will take questions. I saw somebody's hands up, and I think his hands went up too early. Maybe during the course of the conversation, his question was answered. I don't know. But if you're still here and you still have the question, now is the time to ask it. Okay, I can see that there are comments in the chat box. Okay. Supporting the conversation. One healthcare provider taking care of 20,000 people is just wild. It's really, really wild. There's a city in the UK, Peckham County, literally called Mushing of Lagos because Nigerians dominate this county. Well, of course, if you live in the Nigeria that we live in today, you would want to move there. See, our policymakers are ruining everything. Well, yes, that's also a huge part of the conversation. Thank you guys so much for following along. So this is time for Q&A. Q&A. If you've been listening and you have some questions, now it's time to ask them. As we're waiting for your questions, I do have a question. So I'm speaking to the policymakers that are ruining everything. There's an argument, and I will not say it's for me. There's an argument that our elders in the profession are the ones ruining everything, and borrowing from the words of Yakubu Bansa. We are given a chance at the table to state what the problem is or to create solutions, and our elders sort of downplay the situation that is happening, the day-to-day realities that we face, like you have said. How do we do that? Because it's like a house fighting against itself. So how do we now conquer that kind of problem before we fight the outsiders?
Thank you so much, Ochanya. And I think that is a very vital question as well. It is sadly the reality that we face in our country, most especially Nigeria, that these politicians have found a way to, get through us. They found a way to get through every other institution out, actually. They've gotten the better of us, I would say. It's quite unfortunate that, of course, the president of Nigeria might just say, look, every single day you, these healthcare providers, you clamor about being left out and all of that. But we have been giving you, most especially doctors, we've been giving you doctors, the Minister of Health, doctors, back to back. These are people that have gone through the system and understood its challenges. We've had several institutional associations the doctor associations, been headed by doctors, the NMA, the NARD. These are people that are given a seat on the table. But you would say, sadly, in as much as there is so much that they have done, there is so little that is translated into the lives of the average Nigerians or the healthcare providers. No matter what you do, no matter your efforts, if the average Nigerian or the healthcare providers don't feel it in them that there is something tangible that is coming to them, they won't see those efforts that you have done. And that is unfortunately one of those things. But I have told myself a long time ago that we cannot continue to talk of the past, not to talk of these elders. We must start, and that is why this kind of fora are important, that me and you sit together, because we know that once we raise our own voices, it goes beyond theirs. It reaches where it needs to reach. Now, we don't just shout, we have our data. Why? Because policymakers are not moved by mere shouting. They are moved by data. We are surrounded by data every single day. We're not making use of it. When we start to chunk out this data, they will listen. And I will give you a good example. The healthcare workforce migration policy. When we started talking about the unregulated working hours, I knew that a lot of people have done studies on it, and it's just on the conference in their one research journal, and it's just sitting there. Some other people have tried to talk about it, but there has not been pressure. So when I came around, I knew that we had to increase people's awareness, people to understand what these healthcare providers go through. But it's not just a word of mouth. We had to show them data. We did that. We had a petition where about 4,700 people signed. That was a document. That was an action. To say we want a document that regulates the working hours of doctors. We never had it. Since the inception of the Medical and Dental Council of Nigeria, which is the sole regulator, since its inceptions, 1961, there was no document, not a single document that regulates the working hours. So now we want it. And these are public saying, we want our doctors to be sane, to be safe, for them to take care of us. So we are signing this petition. We want you to take action. They had to take action. We sent it to the Senate. I had basically no one in the Senate. I have no seat in the Senate. But our voices, that document went to the Senate. It was read on the floor of the Senate. It was passed on to the community, on ethics committee and whatever. And that was where the conversation started. The nation started realizing that they need that. A research I did, it was just 58 doctors that participated in the first research I did. I presented that research in America. It's data. It's not much, but it is data. And that conversation moved our nation towards creating a document. When the new president came of a National Association of Resident Doctors, he met this document. He met me with this document. He had the ambition also to make sure that we have a regulated working hours as well. Everybody has it. So what made it easier for them is because now that we have data to show of it, and not to take away credit from them as well, they also have data, they also have research that they have done as well. All of us coming together. The first decision he made when he assumed office was, look, because now we have data, we can now tell our people confidently that no one should take 24 hours call again. Yes, no one should take 24 hours call again before the government will take action. People still take 24 hours call, but people know that even if your hospital doesn't allow you, you know that there is an official statement somewhere that if you decide not to, you can use as a reference.
Thank you so much for that. Thank you. I think that speaks a lot to the grit and the determination of the younger millennials and the Gen Z health workers. So I think we can also like give it up for the new generation of health workers. They're doing a lot and they are prioritizing their mental health, and nobody's going to tell them otherwise. And for that, I think we are doing something. We're moving forward. So if you're a Gen Z health worker in the house, a young millennial, please give it up for yourself, because this is us taking a stand and saying, no, we are going to survive whatever it is, the system that you have put up before. So I can see that Ahmed Musa has a question. You can go ahead and mute yourself and ask your question.
Okay, good morning, everyone. My name is Ahmad, and I'm joining from Zambia. I would like to start by saying we're grateful, Dr. Alamin, for the opportunity to learn from your expertise and experience. And your insights on this subject are both timely and valuable, and we appreciate your willingness to share them with us. Thank you for allowing us with this session with you, and we look forward to engaging and enlightening discussions like this one. So my question is, in your experience, what are the most common signs that a caregiver is experiencing burnout?
Thank you so much, Ahmed Musa. Is that Ahmed Musa from Zambia? Of course, we have listed, I think, some of them in our previous slide, but I'm just going to talk about them. The most common one actually is, the feeling of not wanting to, you don't feel fulfilled like coming to work anymore. You just come to work because you're on the roster, and you just feel that passion of yours just fading away. And I think that mentally just takes a toll on you. Usually that is the first one before it sets to, depression or the anxiety of every day you have call back to back, or you have presentations back to back. Then you now start having it taking a physical toll on you, where you start having, constant headaches, blood pressure issues, and those that are susceptible to faint, and those unfortunately who would lose their lives. That is the most extreme of it, lose their lives. So it's a spectrum, and of course everybody experiences it differently, but these are the common themes that you would find, which that is the indicators of burnout. I hope it answers it.
Thank you so much. I hope that answers your question. Okay, he's clapping, and so I believe that answers his question. So before we go, because the time is fast spent and we've had a lovely conversation, before we go, if you are here and you have something, your take home from today, like what is that thing that you've held on very strongly to? Put them in the chat box. Sorry about that, please. You can put them in the chat box. And also, our last question to you today would be that for everybody who has joined this call today, Dr. Alamin, what is that one thing that you hope that every young healthcare worker always has at the back of their mind as they practice, as they go through life as healthcare providers?
Thank you so much for that. I would beautifully say this. This is from one of my mentors, my consultants. He has this approach to life. And I think it is beautiful as healthcare providers that we understand that we are there to take care of people's lives. And the challenges of the system might frustrate us, but we should always remember our primary focus is that of saving the patient's lives, giving our best to the patients. Now, when you feel you're starting not to be able to give your best to the patients, please move away. Because a decision by you, one wrong decision by you might be a life-changing decision for the patient and their families as well. This is, I think, very important. When we're talking about, burnout and all of this, yes, we have challenges. Yes, we have systemic failures. But when you go to the hospital and you see yourself not being able to give your best, or when you are giving your best but hurting people, then you should move away. And this is why it is important for you to take care of your mental health. It's non-negotiable. It should be non-negotiable for you. You should take care of your mental health. When a place is very toxic for you, find a place and move away. We've had instances of where, I'll be quick, we have instances of where healthcare providers do surgeries and leave a towel inside the patient. The patient lose their lives. No matter how you try to explain that you were frustrated, you were tired, while we're trying to fix the system, we should also understand that while mistakes happen, it shouldn't be one that just comes from the fact that our only explanation is that we are tired. I think that would go a long way. Prioritize your mental health and do not let it be negotiable. Thank you.
Thank you so much, Dr. Alamin. I can see the applauses. Yes, please, a big round of applause, a virtual round of applause for Dr. Alamin. Thank you so much for your time with us. Thank you for, again, allowing us a tour into your brilliant, your brain and the research you've done so far, for sharing with us, for carrying us along. Thank you so much. It has been a very insightful conversation, I'm sure, for myself and for all the young people in this call. We're going to take what you have shared with us closely to heart as we practice and as we go every day into our lives. Before we go, we'd like to take a quick photograph of everybody on this call. So if you're somewhere where you're comfortable, you're looking cool, feeling fly, please put on your camera and let us just take a quick snapshot. Thank you. Yakub Obanta, Humphrey, yes, I can see. Thank you very much. Thank you. We're waiting for a few others. Zainab Musa Waziri, yes. Ahmed Musa from Zambia, thank you very much. Aliu Abdulatif, yes, thank you, thank you. Say cheese for the camera. Thank you all for joining. I hope you enjoy the rest of your day. Thank you so much and goodbye.
Thank you, everyone. Thank you for having me.
Bye.
Bye-bye.
I think we cannot exit the meeting since the time is up, right?